Hello, everyone. Can you guys hear me? If you can, please write down in the chat box. If you can see the screen and you can hear me. Great, awesome, awesome. Great, awesome. All right, let's get started. Uh, okay, now let's talk about abnormal uterine bleeding, high yield topic. Okay, and most high yield here is going to be the causes of abnormal uterine bleeding, which is the palm coin, but we will talk about that. Here, the first thing is the deviation from normal menstruation volume, duration, or frequency. Look, what are we talking about? We're saying, again, make things very simple. Abnormal bleeding, right? So what is abnormal? Could be the volume, could be the duration, could be the frequency, could be the regularity, or it could be some instrumentational or instrumental bleeding. Intermenstrual, my bad. Intermenstrual bleeding, okay? What are the causes of all this? Well, the causes are easy. They're palm coin. And again, first aid does not mention anything extra. So I guess if they're mentioning as a mnemonic, that means these causes are important, okay? So we'll break down into structural, in the structural or non-structural. In the structural, we have a polyps. We have P is for polyps, A for adenomyosis, leiomyoma, malignancy or hyperplasia. So this is all palm, right? The coin are non-structural, in which you have the coagulopathies, ovulatory, endometrial, iatrogenic are not yet classified. So basically, if you look here, and we will talk about the pathology, then this all will make sense, that any of disease can cause abnormal bleeding. Okay. So terms such as dysfunctional uterine bleeding, menorrhagia or metorrhagia, polymenorrhea, and oligomenorrhea are no longer recommended. So what you want to use for all of that is the abnormal uterine bleeding. No matter if there is more bleeding, there is oligomenorrhea, less bleeding. In any case scenario, you want to use this name. So you will think about palm coin. Again, this is more like to memorization, but I think if you first do pathology and then look back here, it's going to be, it's going to make sense. It's going to make things easier. So that's pretty much what we have for that one. Let's move on with the pregnancy, and I will review the whole page once we are done with the whole page. So let's look at pregnancy now. Pregnancy high yield is the fertilization or conception most commonly occurs in the upper end of fallopian tube. High yield, most common location is ampulla. Most common location is going to be the ampulla of the fallopian tube. Okay. Occurs within 1 day of ovulation because the egg has a life of only 1 day. So if it does not occur in the 1 day, the egg is going to die. That's why it has to occur within the 1 day of ovulation. As soon as the egg comes into the fallopian tube, it must get fertilized within 1 day. Otherwise, the egg is going to die. Okay. Implantation in the uterine wall occurs 6 days after fertilization. And syncytial trophoblast would secrete HCG, which is detectable in blood 1 week after fertilization. And on home urine test is going to take 2 weeks after. We did talk about this, how the syncytial trophoblast makes HCG, but again, this is again important. That's why they're mentioning here that in blood you can right away see it within 1 week, but in urine it takes 2 weeks. Okay. So blood is going to be right away rapid telling us that there is pregnancy. Otherwise, urine takes about 2 weeks after fertilization. And when does fertilization take place? 6 days after ovulation. I mean, fertilization takes place right away within 1 day, but my bad, implantation takes 6 days. So as soon as we are fertilized and the implantation takes place, that syncytial trophoblast would secrete beta-HCG into the blood within 1 week and into the urine within 2 weeks. The next is embryonic developmental age is the time since fertilization. Okay, so from this point, we can start calling that an embryonic or developmental age, which is used in embryology, right? Now, we do use another age as well. That's called gestational age. That is the time since first day of last menstrual period. Okay. Again, gestational age is going to be the first day of last menstrual period used clinically. Okay. High yield names are going to be the gravida. What is gravidity or gravida? Is the number of pregnancies. And what is parity? Para is the number of pregnancies that result in live births. So whenever there is a live birth, that's the parity. Gravidity is any number of pregnancies. Okay, that's called gravida. Okay, taking a look on the left side here, on the right side actually here, we have the placental hormone secretion generally increases over the course of pregnancy, but HCG peaks at 8 to 10 weeks of gestation. So that's very high yield. If you look, we kind of think about that HCG in the pregnancy is going to be high and it's going to get higher and higher, but that's not the case. So if you look here, so it kind of peaks at 10 weeks. So let's say this is 14, right? This is about 10 weeks. It peaks at 10 weeks. After that, it'll just decline. Okay. That's important to know, that you have beta HCG, which is, again, we said the beta HCG, again, let me highlight this part because this is high yield point, that the beta HCG is going to come from where? Syncytial trophoblast, right? So syncytial trophoblast is going to secrete HCG, right? HCG. Now this HCG, which is secreted by syncytial trophoblast, is going to be peaking at about 8 to 10 weeks, as we can see in this picture. It is peaking at this 8 to 10 weeks, but then after that, there's just decline. Okay, and the gestation is still there. If you look at the weeks of gestation, you have 14 weeks, 21 weeks, 28, 35. It goes up till 42 weeks, right? But there's a decline in beta HCG. Okay, that is important to know. Other than that, just remember one thing that we did talk about as well, prolactin. Look at prolactin here. Prolactin start from the pregnancy. It is just, let me just zoom in so you can see prolactin. So this is the prolactin. Okay, so it's just goes up in a linear fashion. It just straight goes up, right? So prolactin at delivery. So let's say they deliver at 37 weeks. So what's going to happen is this prolactin level will peak at delivery and prepares the breast for lactation. So increase in prolactation after the delivery is going to cause an ovulation, which is also known as lactational amenorrhea. Basically, because when you have increase in prolactin, there is inhibition of GnRH, if you recall, right? When you inhibit GnRH, now you're inhibiting FSH and LH, right? So when you're inhibiting FSH, LH, that's going to cause amenorrhea, no menstruation, right? So no menstruation, basically, again, so there is no egg to be released. When there is no egg, it is also known as contraception. The prolactin acts as a natural contraceptive. That's one thing. Second thing, it causes something known as lactational amenorrhea, because there is no menstruation after pregnancy if the lady is breastfeeding. Because when the baby feeds on the milk, does the suckling response, if you recall, again, very high yield topic here, if you recall, we said the suckling would cause prolactin to be released. And that prolactin, again, the normal function of prolactin is to inhibit GnRH, and that is going to cause lactational amenorrhea, natural contraception. Prolactin, okay? Just remember that. Okay, now let's talk about something. I think they did talk about it in renal. Let's just see this, okay? Uh, Physiological changes in pregnancy. So in the high yield physiologic changes in pregnancy, you're going to be looking at in the respiratory, you have the mild respiratory alkalosis. Okay. In the cardiovascular, you have increase in cardiac output, increase in heart rate, and peripheral edema. Again, because you have increase in volume now because of pregnancy, right? So you are going to cause increase in cardiac output, and you need increase in heart rate, which occurs in the later pregnancy, and also that fluid also goes out in the extravasal spaces, causes edema. In the gastrointestinal, you have constipation, GERD, and gallstone. The baby, the gravid fetus, is going to push on the stomach. When it pushes onto the stomach, it's going to cause GERD, right? When the baby is getting bigger and bigger and bigger, guess what? It's pushing on stomach more, is going to open that sphincter and lead to GERD, right? Constipation, gallstone. Why gallstones? Because if you recall, we said progesterone. Progesterone causes what? Progesterone causes stasis. Stasis of it causes stasis of the gallbladder. So when you have the stasis of gallbladder, this is gallbladder, right? When you have stasis, there's going to be supersaturation of the contents. That's going to cause gallstones. Okay. You have in the skin, you have melisma, estrogen, linea nigra, areola darkening, stria gravidum, varicose veins, and pulmonary erythema. All of them are there. Most are often due to estrogen, increase in estrogen levels. Now, in endocrine, what we have is increase in insulin resistance and secretion. Why do we have increase in insulin resistance in pregnancy? Well, that's due to the fact that there is a physiological, so this is going to be total physiological resistance, okay? There is an increase in maternal insulin resistance during the second and third trimester. So let me just write second, third trimester of pregnancy to ensure that the good supply of glucose and amino acids are going to the fetus. Okay, and who's doing this insulin resistance in pregnancy? Well, it is done by an hormone known as human placental lactogen. We will talk about that, but here it's as a clue you can see here the green one. It's called the human placental lactogen. So this guy, what is its function? Its function is basically just remember it this way: human placental lactogen is going to take all that glucose and all those amino acids, and it's going to send them to the fetus instead of giving it to the mother. Although the mother has all these glucose and amino acids, but she's not going to live on it, meaning she's not going to take all those. And that in turn we will call insulin resistance, because there's a lot of glucose in the blood. And we say, hey, why isn't insulin working and putting that glucose in the body, right? Well, the answer is because, and we will talk, I think the topic is going to come up, but the simple thing here is just remember, human placental lactogen is going to cause increase in insulin resistance, and that would cause increased glucose levels within the bloodstream and maternal circulation, and glucose will be freely. Why do we have increase in blood? So that a lot of glucose can freely cross that placenta and provide energy to the fetus. And if it's not making sense right now, don't worry. We will talk about it in a bit. But that's the mechanism of increase in insulin resistance and gestational diabetes mellitus, right? Okay, now next thing we have is increase in lipolysis. and fat utilization. Uh, that's also very high yield. That the mother, okay, mother is just going to take. So again, mother is a human. She also needs some food, right? The body needs everything. So if we are putting all that glucose that we give from outside to the mother, right? Mother is eating, getting glucose, getting all those amino acids. But we are saying, no, hey, because of HPL, which is human placental lactogen, all that glucose is just goes, the fetus takes it. Amino acids, or fetus takes all that. So how is mother having the energy? Where is she getting the energy from, right? That's the question. Well, that is only the mother is going to take all those fats. It will take maternal source will be increasing lipolysis. So all these lipolysis, meaning all these fats, when they come down, when they get destroyed, or breakdown, I should say, when there's a breakdown of all these fats, which is known as lipolysis, these fats are taken up by mother, and the mother is going to take those fats only, right? So it's a big thing. You're not eating your glucose, not having your amino acids, all to the sacrifice of fetus. Okay. But that's not the choice. There is no choice. Why? Because nature has made HPL there. Okay. So with that, let's take a look at more. So we have increase in total binding globulin or thyroglobulin, binding globulin, something like that. But it binds to TG, thyroid hormones, T4, T3s, right? Increase in CBG and increase in sex hormone binding globulins. That's all endocrine. And this is all due to the fact that you have estrogen more, right? Then you have immunologic, you have dilutional anemia because you have a lot of volume. And that's going to, let's say you have 100 RBCs present. Let's just give you an example here. 100 RBCs in let's say fluid. We have 100 ml of fluid. And we will see a lot of RBCs now because they're proportional. But now when you increase the fluid level, let's say to 300 ml now, and you still have only 100 RBCs, that's called dilutional anemia. Although you are not anemic, but again, you have dilutional. A lot of volume is there, so you think it looks like that you're anemic. Hypercoagulable state and increase in micronutrition requirements. In the renal, high yield is renal. In renal, what we have is increase in GFR. Increased GFR would give you decrease in bun and creatinine and mild glucosuria, because all that glucose, I mean, when it is in the blood, guess what? What's the level of glucose that's going to go out of the kidney if they exceed the level? I think it's 270 or 290, right? When you exceed this level, I think it's 290 possibly. 290. When you, and this is going to be in the kidneys again, when you have level of glucose, blood glucose level greater than 290, all these transporters are saturated. Meaning, in other words, you can say you have glucose and you have the reabsorbing transporters. So no matter what glucose goes in the urine, gets reabsorbed. But at the level of 290, meaning it's so much glucose going into the urine that these transporters, which are putting them back into the blood, now are saturated. Now they can't work anymore because they're doing extra work on it. For example, they are just doing over job. They are putting their max. When they're putting their max, whatever is left over above 290 is just going to go out in urine. And when it goes out in urine, we call it glucosuria. That glucose is going out in urine. Okay. Proteinuria, hydronephrosis, and hydroureter more prominent in the right kidney. Okay. Musculoskeletal lordosis and joint laxity, because that fetus is sort of pushing it forward. So you have lordosis and joint laxity. Okay. So here, we did talk about glucosuria, but we did not talk about how your proteinuria is going to happen, right? So just remember one thing, that when you increase GFR, And first of all, why are we increasing GFR in the kidneys in pregnancy? Well, again, you have increase in blood volume. Let's just put it here. Increase in blood volume. That increased blood volume will cause increase in GFR. Not only increase in GFR, but also cause increase in cardiac output, as I mentioned, right? So, but here, increase in GFR is going to cause placental increase in creatinine, hormone clearance, and it's going to cause increase in glomerular basement membrane permeability. Increased GFR increases glomerular basement membrane permeability. Well, they're more permeable. When they are more permeable, there's going to be leakage of proteins into the urine. But there's a level now that is called trace proteinuria, which is less than 300 milligram per 24 hours. And this is important. This is called again trace proteinuria or microalbuminuria, something like that, right? But again, the level is less than 300. And why this proteinuria is happening again? Because you increase GFR, that's going to cause increase in glomerular basement membrane permeability. When they're more permeable, more protein goes out. That's called proteinuria. Okay. With that, I think there's a last thing. Let's mention about why do we have alkalosis or respiratory alkalosis. Well, respiratory alkalosis is again in pregnancy. Let's just mention here in pregnancy, what's going to happen is you have an increase in progesterone, right? And that increase in progesterone stimulates the central respiratory drive. That's high yield. That progesterone stimulates central respiratory drive, and that respiratory drive causes increase in ventilation. So increase in respiratory rate, which is called hyperventilation, right? That hyperventilation, or in other words, you can say shortness of breath, all the same thing. SOB, shortness of breath, increase in respiratory rate, hyperventilation, same thing, right? That hyperventilation is going to cause respiratory alkalosis. And why is it causing respiratory alkalosis? Because you're throwing out that acid. When you have increase in respiratory rate, you are throwing out that's carbon dioxide, CO2. What is CO2? CO2 is acid. When you throw out that acid, all you're left at basic environment, right? So that's why in basic environment, where specifically are we talking about the whole blood, body, or are we talking about in lungs? We're specifically talking about lungs here. Hyperventilation occurs in lungs. That's the lungs things, right? So when you throw out that carbon dioxide, when you are ventilating, hyperventilating, I should say, or when there is increase in respiratory rate, or when there is shortness of breath, in other words, again, respiratory rate is high, and that is going to throwing out a lot of carbon dioxide, which is acid. When you throw out acid, you're left with basic environment, and that basic is going to be alkalosis. Which location? We're talking about respiratory alkalosis, and that is exactly what is mentioned here. If you look, you have in respiratory, we have alkalosis, and this is all the mechanism behind it. Now, let's talk a little further here. When we have respiratory alkalosis, there's going to be compensation, right? That compensation is going to be metabolic compensation. So there's going to be a metabolic compensation to it, and that is going to be increase in bicarb excretion. So the easy way, just remember one thing. I think if you go back to the renal section, you will see that. But just remember one thing, very, very important, very easy. The compensation is always going to be the same thing as initially what you were doing. So for example, let me give you an example, because make this acid-base balances very simple so that you don't even have to think about anything. Okay, just whenever you see some normal physiology, you think about decomposition right away, very easy. So here we said increase in CO2. We are throwing out that, we are dumping up that CO2 or throwing out that CO2 in the respiration, right? So when you increasing CO2 excretion, right? So what we got to do is the compensation has to be the same. It's like eye for an eye, meaning if you're throwing out carbon dioxide, for compensation, you got to throw it bicarb, man. Simple as that. You got to throw it bicarb. So here, What is the compensation? Increased bicarb excretion. Eye for an eye. It can't happen. So compensation is simple. Just make things very simple. Acid-base disturbance. You're throwing out something. As a compensation, you got to throw the other thing. Okay, you say, hey, eye for an eye. Simple as that. If you're retaining, other way, you can also think about the other way. If you're retaining CO2, the compensation, you have to retain bicarb. Simple. Retain. That's the compensation. Okay. So in summary, what I'm trying to say is the arrows match. It's eye for an eye, meaning if you're throwing out something, you got to throw the other thing which is against it. It can't happen that I'm going to keep one guy here, but the other guy I'm going to just kick it out. No, I can't do that. That's not equality, right? We got to be equal. This is human body. We say, hey, we believe in equality here, 100%, right? So what is equality? I'm going to throw out this carbon dioxide, no matter whatever it is. I'm going to throw out my bicarb as well, which is basic. And that's the compensation. I hope this makes sense. If this does not make sense, go back to the renal compensation. Hopefully that would give you a clue. But this is exactly what I mentioned over there. So same thing. But high yield, but simple. See, simple. Don't think about it. Eye for an eye. You throw out carbon dioxide, you throw out bicarb. You keep CO2, make acid. You going to retain bicarb to compensate. And it's going to be opposite. Let's say if you're throwing out your bicarb, you got to throw out your CO2. If you're retaining your bicarb, you have to retain CO2. That's all compensation. Okay. Okay, with that, now we are doing this, and this helps. And whatever we are doing respiratory alkalosis for compensation. We are increasing again. We are increasing bicarb excretion, right? And this helps facilitate the transport of CO2, which is an acidic waste, from the placenta as well, right? So again, that CO2, which is also coming from placenta, because remember, placenta is taking all that oxygen and again throwing out that carbon dioxide, which the mother has to throw out, right? So we are doing all this that we are increasing respiratory rate, throwing out that more CO2, and that helps facilitate the acidic waste which is coming from fetus, meaning the carbon dioxide which is coming from fetus. It's also going out through this process. Okay, this is very essential. And that is going to cause, again, increase. So when you increase in urine bicarb, there's going to be increase in urine bicarb, and that is going to cause pH to go higher. So it's going to be pH greater than 7.45. And PaCO2 is going to be less than 40. But not important. Forget this point. But what you need to know is, okay, let's just quickly go through this whole page and move on. Okay, now let's talk about here. We talked about abnormal uterine bleeding. Abnormal uterine bleeding is going to be anything with a volume problem, duration problem, frequency problem, regularity problem, intermenstrual bleeding problem. Anything is the abnormal bleeding, right? And that abnormal bleeding are a couple of causes here: structural problem or non-structural problem, meaning a structure, there's a polyp in this as a structural problem. Adenomyosis is a structural, but leiomyoma, malignancy, hyperplasia, these are all structural problems. Non-structural meaning it is not the structure of the site where the bleeding takes place, but it is something else, non-structural, and that's going to be coagulopathies, ovulatory problem, or endometrial, iatrogenic, from outside you introduce something, not yet classified. We don't even know what that is, but that's pretty much what we have. Important now here is going to be the pregnancy. The pregnancy fertilization occurs in the ampulla, high yield. Implantation takes about 6 days after fertilization. Syncytial trophoblast secretes HCG. First week is going to send that into the blood, and second week is going to throw that out into the urine. Embryonic development, or embryonic or developmental age, is the time since fertilization. Is the time since fertilization. And gestational age is time since first day of menstrual period. So again, if we say gestational age is from LMP, which is last menstruation, last day of menstruational period, until today, until let's say whatever the day is today, that's going to be the gestational age. And the embryonic age is your from last menstruational period until today and minus 2 weeks. So you can do this way. Last menstrual period, again, same way until today, minus 2 weeks. And that is your embryonic developmental age. Okay. Then you have the gravida or gravidity. There's a number of pregnancies. And then you have parity. Again, number of pregnancies, and the parity is just the number of birth with gestational age greater than 24 weeks. The live birth is always going to be greater than 24 weeks. Anything less than 24 weeks, you don't even call it live birth. Okay. So parity comes if the pregnancies, they have reached greater than 24 weeks of gestation. Okay. While the gravity, they don't care about weeks. They say if you're pregnant, the gravity is going to go high. If you're pregnant means gravida. There is gravida. Doesn't matter if it's a live birth, non-live birth, does not matter. For the parity, it matters. Is the number of pregnancies same thing as above, but that resulted in live birth basically means that the live birth, meaning you have greater than 24 weeks of gestation. Okay. And that's the parity. Again, number of births with gestational age greater than 24 weeks. Okay. Placental hormone secretion increases over the course of pregnancies, but so they're saying simple way, everything, all these hormones, they're increasing. None of them is going down except one, which is HCG, which is going to go down after 8 to 10 weeks. So what are the hormones? Which are the placental hormones? That's the HPL. That's the estrogen, progesterone, and prolactin. All of them are going to go high in pregnancy. Linear increase in all of them except one, HCG. Remember one thing, HCG goes down after 8 to 10 weeks. Okay. And more importantly, remember where it's coming from, syncytial trophoblast. Then you have the changes, high yield changes are going to be respiratory alkalosis due to the fact that progesterone stimulates the central respiratory center, right? That causes increase in respiratory rate, which causes hyperventilation, which causes respiratory alkalosis, compensation, the throwing out bicarb. Increased blood volume causes increased cardiac output, gallstones, GERD, constipation, estrogen-derived melisma, linea nigra, areolar darkening, and all of that. Endocrine high yield insulin resistance is increased due to the fact that you have HPL. Lipolysis is used as a source for maternal use. Then you have this dilutional anemia. Again, high blood volume causes dilutional anemia, increase in cardiac output, and increase in GFR. So this is sort of a tried side of a thing you can say, okay. Increase in GFR, that's going to increase permeability, causes proteinuria, mild glucosuria, because the transporters will oversaturate. And then you have lordosis and joint laxity. With that, let's move on. Okay, so Dr. Semarine, we have lordosis, as you know, look at the back here. Let me see. So this is sort of curved. If you look here, because of the, let me change the color here. Okay, so because we have the pregnancy, right, the fetus is going to push on the back, right? It's an extra weight, right? And it's growing weight. And that extra growing weight is going to have cause lordosis. which basically simply means that you have sort of inward curving, just inward curving of the back. Normally there is inward curving, but it's not this profound. But here, due to the fact that you have now weight, which is going to push on this, so there's going to be profound lordosis. Okay, and that's just called inward curving of the inward uh, spinal cord or lower back. Okay, guys, let's take 5 minutes break. I'm gonna put up the timer uh, for 5 minutes, and then yes, it is everything here. It's all physiological, right? 100%. And that's why with the pregnancy there is a pain, you know, back pain. But it's when the fetus is out, these joints they're laxity, meaning they're more laxed. Uh, they can easily they're easily to go into any position, right? Because they're laxity, meaning they have the flexibility now. But after pregnancy, they go back to the normal space, and everything is normal after pregnancy. And this is all occurs within pregnancy as a physiological state. So let's just take 5 minutes break, and we'll get back. I'm gonna put up the timer. Okay, let's talk about this thing. Okay, hopefully you can hear me. Okay, just want to mention one more thing here, which is again high yield. Uh, so one high yield point that I want to mention here is going to be for the cardiovascular. So for the cardiovascular, we said again the whole point in pregnancy is that you have increase in the blood volume, right? That increased blood volume is causing every single thing here, right? Increased cardiac output and everything. But now, important point is going to be that with pregnancy, what you have is due to the fact that you have increase in blood volume, which is also known as increase in preload, right? That increase in preload is going to cause increase, is going to cause a murmur, and that is called pulmonic flow murmur. Okay, and that is there's one murmur with pregnancy associated murmur, and there's going to be an sound S3 heart sound. S3 heart sound will be there. Okay, two high yield points. Again, you have a murmur associated with pregnancy, and you have S3 heart sound. Again, everything physiological here, and it's going to cause S3 heart sound. With a murmur, you can think of is due to the fact that you have increase in blood flow across the pulmonic valve. So that is going to cause pulmonic flow murmur, okay, because you have increase in blood flow across the pulmonic valve. Now, with this murmur, let's talk about the location of this pulmonic flow murmur. This is going to be a systolic murmur, which is best heard at left sternal border. And if you want to know more about this, the location, you can go back to cardiovascular. But important point is just remember there's going to be a murmur, which is again physiological, and physiological S3 heart sound associated with pregnancy. So with that, we are moving on to the next part here. We have human chorionic gonadotrophin, right? This human chorionic gonadotrophin source is going to be syncytial trophoblast of placenta, right? Again, this is the same beta HCG or HCG, human chorionic gonadotrophin, okay? It arises from syncytial trophoblast. Its function, it maintains corpus luteum, and thus the progesterone. Again, if you recall, we had a developing follicle. That developing follicle, when the egg is out of that developing follicle, that is now we call that corpus luteum. And when the corpus luteum degenerates, we call it corpus. From corpus luteum, what do we call corpus callosum? What not corpus? I don't know. What is it? Corpus albicans here. So again, developing follicle. When the egg is out, we call it corpus luteum. The remaining part is the corpus luteum, right? And after that, and this guy is the one which makes progesterone. Okay, progesterone. And after it gets, the destruction of this is known as corpus albicans, or when it dies, it's known as corpus albicans. Again, the names are high yield. Okay, with this, let's talk about the functions, right? So function of this beta HCG, it maintains corpus luteum. So it is maintaining side of the structure so that you can keep producing progesterone for the first 8 to 10 weeks of gestation by acting like LH. High yield beta HCG acts like LH. Otherwise, there's going to be no luteal cell stimulation, leads to abortion. Okay. Then you have the luteal placental shift is complete after 8 to 10 weeks. So they're saying simple that, again, if you very high yield point, which you have to know is this, you have progesterone, which is made, let's just actually mention it in a way that you can understand. So you have corpus luteum, which is going to make progesterone, but till what age? About 8 to 10 weeks of gestation. After that, the whole shift goes to placenta, and that is known as luteal placental shift. So now placenta is going to start making that progesterone after 10 weeks, and it's going to keep producing that progesterone until you deliver the placenta. So going back here now, luteal placental shift is complete after 8 to 10 weeks. Now after that, you have the placenta, which will synthesize its own estriol and progesterone, and corpus luteum would degenerate, and that degenerated corpus luteum is called corpus albicans. Okay, now this beta HCG or ACG is detected, is used to detect pregnancy because it appears early in the urine, and we said about 2 weeks it come in urine, right? Again, beta HCG has identical alpha subunit as LH, FSH, TSH. We talked about it in endocrine, but beta subunit is unique, detected by pregnancy test, but structurally similar to TSH, high yield. We did talk about it over there, that alphas are similar. If you look, we said alpha is similar to TSH. We're now saying beta is also similar to TSH. So isn't it simple that you said beta HCG is like TSH? It works just like TSH? Yeah, if you're thinking about that, right, for sure. Because alphas are the same, betas is the same. What's there left? I mean, there's nothing left. I mean, they're all same. They are the twins of pregnancy. I don't know, but whatever it is, how are you going to remember this? You can call it twin humans, okay? Twin humans. And what is twin humans for? T for TSH, H for HCG. They're the twin humans, meaning they got the same alpha, they got the same beta subunits. They're going to act the same. So structural similar to TSH. So if there is an increase in HCG, which there is an increase in HCG in pregnancy, it will cause hyperthyroidism. The mother is going through a lot. Wow. Look at that. Increase in HCG causing hyperthyroidism. HCG is increase in multi-fetal gestation, right? Hydatidiform moles, choriocarcinomas, and Down syndrome. High yield points that HCG is not normal, but there is a very high levels in multi-fetal gestation. That makes sense because you have more fetus. But here, hydatidiform mole, choriocarcinomas, and Down syndromes. HCG is decreased in ectopic failing pregnancy. Edwards syndrome and Patau syndrome. These two last points are very high yield, and you must remember it. And then you have, so what we really have here is going to be, again, getting back here, very important point is going to be that we have got to know this. Okay, the beta HCG comes from where? Syncytial trophoblast. Syncytial trophoblast is going to give that beta HCG, which we will see in urine within 2 weeks, but within 1 week we can see it in the bloodstream, right? Now, and we recall, if you recall, 8 to 10 weeks, this beta HCG goes up higher, peaks and goes down, right? And why? Again, why is this 8 to 10 week important? Well, it is important because, as they mentioned here, it maintains the sole job of beta HCG is to, first of all, to show you, hey, I'm pregnant. Second thing is going to be, hey, I got to maintain that corpus luteum so that we can make that progesterone. We do not want to stop this progesterone because this is the guy who is going to keep that uterus into those, if you recall, spiraling of arteries, putting more glands, making it very nice environment for the fetus to implant and to grow, right? So we need that progesterone. And for the progesterone, we need corpus luteum because corpus luteum makes progesterone. So who's maintaining for the corpus luteum to live? For example, if you recall something, let's go back into a little bit details here. So if you, when there is going to be an egg released, right? And when there is egg is released, it leads to corpus luteum, right, being there. So this is developing follicle. Egg gets relieved. There's going to be remaining. It's going to be called as corpus luteum. That corpus luteum is going to make progesterone, right? But guess what? If this egg does not get fertilized, So there is no production of HCG. When there is no production of HCG, corpus luteum just dies right away, like within 14 days, right? This is total normal. But when there is fertilization, there is going to be syncytial trophoblast production, and those syncytial trophoblasts are going to make beta HCG. That HCG is going to maintain corpus luteum to keep on secreting progesterone so that we can maintain the walls of endometrium, so there's a proper nutrition, proper comfort to the fetus when it is growing. But corpus luteum is a very small thing, right? And that is just going to how much progesterone it can secrete. As the fetus grows, we need more and more progesterone to support it, and we can't do it from corpus luteum. We need a bigger structure. That's the placenta. So for 8 to 10 weeks till placenta properly develops. If you recall, placenta develops by 8 to 10 weeks, right? So properly develops by 8 to 10 weeks. So once we have that, then we go from luteal phase into the placental. There's a known as a luteal placental shift. From the corpus luteum, we are going to shifting the whole thing to placenta. So the placenta can make progesterone, and that progesterone will be there till the placenta comes out. Hope that makes sense. Okay, let's move on with the next one. We have human placental lactogen. That is exactly what we were talking about in the previous page. It's known as HPL. HPL is also known as human chorionic mammotropin. Okay, mammotropin. Well, the source is the syncytial trophoblast of placenta. Okay, guess what? Who else is coming from? Here, syncytial trophoblastic placenta. That's HCG. So, can we call all the things that are coming that are named as human placental lactogen or human chorionic gonadotrophin? They are all coming from syncytial trophoblast. Yeah, you can say that, right? Easy way. So syncytial trophoblast is gonna make the human. Whatever human, you have the placental lactogen and human chorionic gonadotrophin, HCG, and HPL, all of them. They are coming from syncytial trophoblast. Again, why am I putting emphasis on syncytial trophoblast? Because there's something known as cytotrophoblast as well. So that's why syncytial is important. Another way we can say synthesis. How do you write synthesis? This is the way, right? Synthesis. So this, whatever syncytial trophoblast is or synthesis, you can think about synthesis being they are synthesizing hormones, HCG, HPL. Okay, and in any way that makes you stick in the mind, Then you have the function. It promotes insulin resistance to supply growing fetus with glucose, amino acid. That's exactly what we said, right? Concurrently stimulates insulin secretion. Now, this is where it gets interesting, okay? So it promotes insulin resistance, and you say how? Question mark. Well, because it is going to supply growing fetus with glucose and amino acids, so it's going to stop the mother from taking all this glucose and amino acids. That's one way. Second way is also stimulates more and more insulin. So inability to overcome insulin resistance leads to gestational diabetes. Again, the problem in the diabetes, gestational diabetes, is going to be that normally human placental lactogen does its job, but the body overcomes that inability, that increase in insulin. The body overcomes it. The body is pretty good at doing homeostasis, right? So they're like, okay, because we are secreting HPL, we will take care of that, whatever insulin we are increased with. But when there's inability, not all people, not every woman, but when there is inability in a mother who's pregnant, who cannot overcome their insulin resistance, and that is going to lead to the gestational diabetes. Again, important high yield point. When there's inability to overcome that insulin resistance, causes gestational diabetes. Okay, so I guess let me just mention one more point here for this one, because this is high yield. Remember that HPL is the one, human lactogen, human placental lactogen, is going to be that you have, let me just draw it this way. So you have HPL, you have maternal, and you have fetal. So that in maternal, we said that you have in this guy, HPL is going to cause increased insulin resistance, right? And also it's going to cause increase in insulin secretion. And insulin is increased, that causes more and more insulin resistance. Now, when you have a lot of insulin, that insulin, just remember that you have a lot of insulin in the body, in the maternal circulation. That is going to cause increase in lipolysis, increase in proteolysis, and increase in blood glucose levels. And this is all due to the fact that you have HPL there. Now, the blood glucose, the important thing is, look, the mother is sacrificing so much that blood glucose is taken up by the fetus. It goes to the fetus, right? The proteins, her own muscle mass or whatever she's taking from outside as a protein, the mother is not taking that. It goes to the fetus. Now, for the only thing that she's going to take as energy is the fats, increasing lipolysis. This is the one which goes for maternal energy source. Okay, and that is very high yield. Okay, with that, let's talk about a little bit of gestational diabetes here. Gestational diabetes occurs, as we said, this increase in glucose and amino acid and increase in insulin secretion occurs specifically by second and third trimester. And that that is the point, that is the time frame when you screen for gestational diabetes mellitus, and specifically by third trimester you must screen, and that is more accurate for the third trimester for the gestational diabetes. So how do you check for the gestational diabetes? That's through the oral glucose tolerance test, or also known as OGTT, oral glucose tolerance test. And that, what is OGTT? Administer 50 grams of glucose and check. Second thing is you check the glucose levels after 1 hour. And if abnormal, if the glucose levels are abnormally increased, you call it gestational diabetes mellitus. So again, first thing you do is you administer 50 grams of glucose, and then you check glucose level after 1 hour. If they're abnormally high, the glucose levels are abnormally high, then you call gestational diabetes mellitus. Okay, that's pretty much what we have for this topic. Let's move on with the Apgar score. Apgar score, we have it's basically the assessment of a newborn vital signs following delivery by a 10-point scale evaluated at 1 minute and 5 minutes. Apgar scores is based on appearance. A is for appearance, P is for pulse, G for grimace, A again for activity, and R is for respiratory. So we check the level, we evaluate at 1 minute and 5 minutes. Okay, Apgar score less than 7 may require further evaluation. And if Apgar score remain low at the later time points, there is increased risk of child would develop. There is increased risk the child will develop long-term neurological damage. Okay. So let's take a look at the Apgar scores now. So Apgar. So the appearance. So again, we are looking at right after the birth at 1 minute and 5 minutes. At 1 minute and 5 minutes. Looking at the appearance of a child, of a newborn. If it's pink, we give it 2 score 2. If the extremities, only the extremities are blue, we give 1 score. If the whole baby is blue or pale, we have 0 score. That's the appearance. That's like the baddest it can get. The pulse, if it is greater than or equal to 100, that's very good. Less than 100, okay, we give 1 score. No pulse. Again, no pulse. You know what that means. Grimace. Cries and pulls away. Okay, grimaces or weak cry. There's a weak cry and strong cry. No response to stimulation. Again, the scores, the higher the score, the better it is. Okay, the lower the score, the problem is. What is the total score again? If you look at the total score, it's going to be 10. Total score is 10. 1, 2, 3, 4, 5, right? 5 times 2 is 10. That's the best score that anybody can get. That's 10 out of 10, right? Okay. But everything is normal till you have less than 7 score. So Apgar score less than 7 is bad, is going to give you have to go for further evaluation. That was the problem, right? So with that, let's look at the activity. There's an active movement, there's arm, legs flexed, or there's no movement. Respiration is strong, cry, slow, irregular respiration, or no breathing. We do it twice for 1 minute and 5 minutes again. At 1 minute and 5 minutes, and we compare this. For example, if the first one the baby had a score of 8, now it's having score of 9 or 10. That's pretty good, normal. But let's say less than 7 is always problematic, because we got to have a further evaluation. And the risk is, the consequence of Apgar score is going to be that if the Apgar score remains low at a later time points, then there is increased risk of child having to develop long-term neurological damage. And that's pretty much it. Now we're talking about here neonatal birth weight. In the neonatal birth weight, we have low birth weight and a high birth weight. So what is a low birth weight baby, or low birth weight, right? Low birth weight is anything less than 2,500 grams. That's the birth weight. Now, if the baby has a low birth weight, there are risk factors. Then why would we have the birth weight being low? That is, if the baby is premature, or there is a fetal growth restriction. When there is, so this is placenta, this is fetus, amniotic sac fetus. If we have fetal growth restriction, meaning the fetus not growing enough because of the space problem, or it's not growing enough due to maybe there's not amniotic fluid enough there, or it's squeezing within the whole amniotic sac. In any case scenario, when you have growth restriction, that will cause low birth weight baby. Or there is a prematurity, that is again going to cause low birth weight baby. Now that low birth weight baby, there is a complication to that, and that complication is you have increased mortality when you have low birth weight. And you have increase in morbidity. So increased mortality and increase in morbidity. Okay. Now, high birth weight baby, which is also known as macrosomia, that is more than 4,000. So again, the values are important. Less than 2,500, more than 4,000. Risk factors are going to be constitutional genetic problem in the fetus, or maternal problem. For example, in obesity and diabetes mellitus, high yield is going to be diabetes. With the maternal diabetes, you have macrosomic fetus, because you have a lot of glucose getting into the bloodstream, into the fetus. They're growing at a higher rate point, and that causes macrosomia, high weight, 4,000. That is why, again, that's why we check for gestational diabetes mellitus, and if they need the treatment, we treat them right away. That's why OGTT comes as an important screening test for this, right? Then you have the complication. Complication again is going to be increase in maternal or fetal trauma. Again, high yield shoulder dystocia. When they're delivering the baby, there's a high yield thing that they can go with the macrosomic baby. There's shoulder dystocia that can happen at the delivery. Okay. So that's pretty much what we have. Let's talk about a little bit extra point here, and that's going to be labor and delivery, which is not mentioned here, but let's just talk about it here. Labor plus delivery. Labor and delivery, important point is you have to know that there are the gap junctions, which are communicating junctions, are very important at the time of labor and delivery. Gap, and question might come up as which junctions are there in the uterus. That's going to be the that is helping in the labor and delivery. That's going to be the gap junctions. Okay, so in the labor and delivery, the estrogen will stimulate the upregulation of these gap junctions. It will stimulate upregulation of these gap junctions. But individual myometrial smooth muscle cells between the individual myometrial smooth muscle cells. So who's upregulating these gap junctions at the time of labor and delivery? That's going to be your estrogen high yield point. Increased gap junctions at the delivery causes all myometrium to contract at one time. Uh, okay, between myometrial cells. Now, another point the estrogen is going to do is also going to stimulate the oxytocin receptors. Oxytocin receptors. And those oxytocin receptors, again, if you recall, they are going to cause calcium transport through the ligated calcium channel. So just remember, calcium gets in, it causes contraction. And when you contract, again, you're helping in the labor and delivery. Okay. So it is, so these two things, so in the labor and delivery, these two combined things, so let me write here, these two combination of these two things, one and two, it leads to coordinated, synchronous labor contractions. Again, very high yield point is going to be that you have labor delivery, you need gap junctions. And who is there to support you in the gap junctions or to increase the gap junctions? That's going to be your estrogen. Estrogen is going to stimulate the gap junctions in the myometrial cells or between the myometrial cells, and estrogen is going to stimulate increase receptors for oxytocin. So oxytocin at the time of labor delivery comes in, causes more and more calcium to get into the myometrium, causes contraction. So these two things together, they are doing coordinated, synchronous labor contractions. Hope that makes sense. And that's pretty much all for this one. Okay, let's review it quick. We have HCG coming from sensory trophoblast. We have HPL coming from sensory trophoblast. HCG is going to maintain corpus luteum till 8 to 10 weeks. And after that, the placenta takes over and makes the progesterone. HCG is also used for pregnancy tests. And HCG has an alpha subunit with same of this, but beta subunit with the TSH. That's why it causes hyperthyroidism. Okay, high yield ACD is increase in couple diseases and decrease in couple diseases. ACD is increase in multi-fetal gestation, more multiple gestations. High identified mole choriocarcinoma Down syndrome. ACD is decrease in ectopic failing pregnancy. Edwards syndrome, Patau. Hey, very important. Look at this. Edwards syndrome, Patau, and Down syndrome. They're all trisomies. Okay. Now here with the Down syndrome, it's increasing beta HCG, and with the Edward and Patau, we're decreasing HCG. Important high yield point. Okay, and that's pretty much all we have. Okay, I guess with this, let's call it a day, and we will continue more and do more pitches tomorrow. Okay. Thank you all for joining, and good luck. Thank you, Marbling, and thank you, everybody else who joined. Mohan Raj, sure, there's a WhatsApp group that we have. I don't know about any Telegram, but I think just search it on Google. Okay, you might find something over there for the Telegram group for any PDFs or anything that you are looking for. Thank you all for joining. Yes, it's gonna be. Hey doctor, it's gonna be here. It's gonna, if you go back, even there's an option that you can play it back. Even when the stream ends, you can always play it back. But right now you can play it back. Um, uh, Hope that helps. Thank you for all for joining. Okay, and the other guy will start up the stream. I don't know when, but you can also join if you want to study uh, as a live study stream with me.